5-year are significantly more when it's essentially the same product. We shouldn't be doing a 5-year ortho case to start. That's an orthodontist's job. Another thing I wanted to talk about from John, our Invisalign rep, he is giving us, let me just share my screen real quick. He's giving us this Invisalign treatment planning workshop. You can see it's $299 deposit, and then once you join, it's completely free. You get 5, CE hours, and it's right here in Thousand Oaks on a Saturday. So I think this is going to be a great opportunity for all of us. I'm planning on going. It is filling up, but John is holding some spots for our group. So we should definitely take advantage of that. So just reach out to Shrujal if you're interested in that. I assume most of you will want to go to the Saturday one, but you're welcome to go to the Friday one.
Maybe Sujal can post that in the email. This
Yeah,
so people know the date.
perfect.
Yeah.
Just a reminder, we have Halcyon at every office. I know doctors are using it, so good job with that. Make sure you're filling out the drug log with, how the dosage and whatnot. So we have we're following all protocols. Dr. J, Dr. Puri, do you have any other things before we hand it over to Dr. Kwan?
No, I'm waiting for his exciting presentation.
There you go.
I just had one thing. Just make sure everybody's double checking. I've noticed, like, when we're treatment planning, sometimes the girls are writing down. You have to double check and make sure they wrote it down right and that it's in the treatment plan correctly. Just double checking that. That's all I have.
Oh, you mean the diagnosis?
The diagnosis, like, if you're saying, like, sometimes the fillings get misinterpreted, like MO, or like they just sometimes just gets put in wrong.
Yeah.
Or even like just making sure it's the right tooth even.
I definitely agree with you, because in our office, I noticed a lot of symbols for a DO, meaning a EO or CC, or, I mean, I've never seen these before. Maybe in our office, what we'll do is just sit down one day and just have a 15 or 20-minute little talk on what the correct symbols look like and check the parity with all the numbers or tooth numbers involved. But we have a little bit of that in the Thousand Oaks office also.
Yeah, we definitely need to make sure that we're presenting correct treatment and doing correct treatment, right? I'm sure we all already double checked that.
Are we using the treatment plan modality where you can sequence the treatment from visit 1, 2, 3? Are docs using that?
I hope you guys are treatment planning and prioritizing it so that your treatment coordinators are on the same page as you, and it's clear to the patient that they don't have to pay $10,000 in one visit. You can phase it out.
I think it helps with their scheduling them too, because if there's clarity what the patient's coming back for and what the sequence is, it really does help the front office, and it's a coordination from the back to the front. And patients like uniformity, that everybody is on the same page.
Yep.
So yeah, definitely helps.
Okay. Perfect. Sujal, you had a quick comment on Invisalign, didn't you?
Yeah, so when we do a scan on iTero, we need to make sure that we create a patient's account on Invisalign doctor site and submit the prescription. So so that way we can get the trays made or retainers made on time and give it to the patients.
So sometimes we are using these scans, or we are simulating the photographs in the Invisalign, either the iPad on the app or on their portal. It is not a committed patient, it is just a prospect. So I think everybody should know that don't put them in as a patient, but more of as a prospect. Because then it starts showing up on their ClinCheck that the clean check has not been completed, and it just stays there. So if it is a prospect, it won't show up as a patient. And then when we start a case, I noticed that in that Invisalign portal, they put on a clean check and it stays there for a few days and maybe a week or so before we get to it, to check the clean check. So whosoever's starting a case needs to make a mental note to go back and
Sir
keep
Jal is
checking.
messaging everybody as well, so you guys have to follow up on it. That's
Yeah.
Sir Jal, I've seen them text and email, so he's the second he gets the email.
The other day, I reminded Dr. Teddy there were 3 cases pending for him, and he didn't expect him to be back so soon. But they were sitting there for 3 days, so he got that done, So just keep that in mind, make a mental note.
Yeah, and use the right address when you're choosing the patient. Make sure you have the right shipping and billing
Right
address.
office, yeah, right office and address, yeah.
Perfect. Thank you guys. Alrighty, Dr. Kwan. You should be host. Yeah, perfect.
Okay, everyone, let me get this on full screen here. So today I wanted to just talk about some topics. I did a talk last time, but today's more going to be about like early in my career, I made a ton of mistakes. And I mean, that's just kind of how it goes, right? There's a lot of uncertainty, a ton of questions, and in dental school, honestly, just doesn't prepare you for what it's going to be like in the real world. And so the topics I'm presenting today are things that I learned during my career and during my residency. And I thought these topics will be very helpful, especially to the new doctors, and maybe provide a refresher for some of the more seasoned doctors. So this is kind of just the agenda today. I know it's late, so I'll try to just go through these pretty quickly. But I want this to be more of like a discussion. I would rather, if you guys have questions, please, like don't feel, don't be afraid to ask. I'll try to answer it the best I can. And if I can't answer it, then I'll write it down and then I'll research it and send out an email. But I'm hoping by the end of today, you guys will have like a better understanding of how to diagnose endodontic problems. Because this is really so basic. And once you master this, it's just such an easy thing to do. I feel like it will greatly improve like your dental practice in general. So this is just kind of, I just found this graphic off the internet, just like kind of illustrating the life cycle of a tooth. And, us as dentists, we're trying to provide our patients with the best care that we can based on our experience, our education, and all through evidence-based dentistry. So that's kind of the key thing. So if we look at the life cycle of a tooth, we're looking at like a healthy tooth. We'll do sealants, class 1 filling, class 2, inlay, onlay, a crown, RCT crown, retreat crown, and then eventually it turned to an extraction and implants. But this, hopefully, this life cycle of tooth, the patient gets to keep their teeth for as long as possible. And that's really ultimately our goal, in my opinion. Oh, let's see. So the chief complaint is pretty key. Like the patient's going to come in, they're going to tell us what their problem is. Because let's be honest, like nobody wants to really come to see us. They're always going to come if they have some sort of pain. So understanding what pain that the patient has is really going to dictate our diagnosis and treatment for the patient. So this one is, I have pain when I bite, I have pain to cold, the pain wakes me up at night, pain is, the patient's having pain. So this is an easy one. And for me, I try to listen to everything the patient says and I put everything in my notes. Because I know we're working as a group practice here and I want you guys to have all the information that the patient gives me just so it's easier for you when the patient comes back to you. So I had this patient last week. She said, I had a crown placed on my tooth 10 months ago because she said the tooth was cracked. I had pain when the crown was put on. The dentist said the pain should go away after the crown was cemented. It never went away. It has been progressively getting worse. Yesterday, I couldn't even breathe normal air or talk to my kids because it was causing so much pain. Like I will literally put all of that in my notes. So this is my notes. It's the chief complaint you can see here at the top. Exactly. I just put word for word. So this is going to give us a big clue about what the patient's chief complaint is, or the problem is. And so the next step after, of course, you do your extraoral examination, intraoral examination, medical history, all that stuff. Then you're going to go to your clinical examination. And so pulp vitality testing, again, this is just so easy to do. So these are the exact steps. Even in my notes, it's in the same exact order. So percussion. So these pluses basically just mean mild, moderate, severe, or negative. So you're gonna check for percussion, palpation. You're gonna basically put your finger on the apex of the tooth and see if they have any pain on the tooth in question and the adjacent teeth and contralateral, opposing, whichever teeth you want to test. For the bite test, again, mild, moderate, severe, or negative. So you can use a tooth sleuth. You can check it on every cusp. I think most of the offices probably don't have a tooth sleuth, so just use a Q-tip and test it on every cusp. Cold is really going to be what gives us the biggest clue if there's an endodontic problem or not, right? So again, mild, moderate, severe response to cold, or I'll put, usually I'll just put NR for no response. And then the numbers that are following the NR are indicating the time it takes for the patient to feel the cold and the time it takes for them for that feeling to go away. So we know for like a healthy pulp, they'll feel it pretty much immediately, and then it'll go away within a few seconds. But if it's like the keyword is lingering, right? If the patient says it's lingering, or that you know it's like throbbing or pulsating for like 30 seconds to a minute, then it's pulpitis, right? Irreversible pulpitis. So with that, then I'll follow up with probing. Probing is key. We need to make sure that the probing of the perio of the tooth is good. Otherwise, there's no point in restoring the tooth or trying to save the tooth unless the patient wants it, of course. Also, if you see furcation involvement, please check the furcation, right? So furcation, so 1 would be normal, 2 would be like it's perceptible to the probe, 3 would be through and through. And then a class 4 furcation would be like when you can actually see it clinically, just looking into the mouth and you can see a through and through furcation involvement. So endo ice for the cold test. And then this is a neighbor's probe, and this is what you should be using to check the furcation. Then I'm going to check for mobility. And I have an EPT, so the numbers, it's out of 80. So the numbers, if it's like 70 to 80, that's going to be pulp necrosis. So it's like 32 would be like more like in the normal range. But this is just going to help me to diagnose the tooth. When I do my cold testing, I'm going to place, I'm not going to use a Q-tip. I'm going to take a piece of cotton roll and make a piece of cotton pellet off of it, because that bigger piece of cotton is going to provide a bigger surface area for you to apply the cold to get a response from the tooth. Sometimes the Q-tip is just not that good. So I would take a piece of cotton so you have more surface area to apply to the tooth. And then always test it on the buccal, buccal or lingual. Don't do it on the occlusal. The buccal is the place that you're going to want to place that piece of cotton. And so now that you've done your testing, now you're going to come to your diagnosis. So of course, normal, reversible, symptomatic irreversible pulpitis is the one that everyone knows, that lingering pain. But the one that I kind of want you guys to, I'll come back to this, I want you to focus on is the asymptomatic irreversible pulpitis. So these are all definitions from the American Association of Endodontists. So their definition is it's a clinical diagnosis based on subjective and objective findings indicating that the vital inflamed pulp is incapable of healing and that the root canal treatment is indicated. These cases have no clinical symptoms and usually respond normally to thermal testing, but may have had trauma or deep caries that would likely result in exposure following removal. So these are the cases where patient comes in for an exam, you see there's like big cavities everywhere, and you ask the patient, are you having any pain? And they say no, right? But you know, as soon as you touch that tooth, You remove the caries, it's going to be close. They're probably going to have pain or sensitivity afterwards. And then the patient comes, so if it's not diagnosed and treated properly, the patient just comes back complaining about sensitivity and pain. This is the diagnosis that you should really consider, because you know that chances are they're going to have pain afterwards, after you touch the tooth. And then there's pulp necrosis and previously initiated, previously treated. And then you're going to follow that up with periradicular diagnosis. So if there's any pain on percussion, it's going to be symptomatic apical periodontitis, sinus tract, chronic apical abscess, et cetera, et cetera. Okay. So I just want to kind of give I'm going to be using these words, success and survival. So I just want to define these terms, because we're going to discuss a lot of literature today. So success is defined as a resolution of apical periodontitis together with asymptomatic responses, and that's considered an endodontic success. Survival is defined as retention of a tooth without symptoms, regardless of the periapical status. So basically, success means the tooth is completely healed back to normal. Survival is they might still have some radiolucencies, but the tooth is still retained in the patient's mouth. Right? Okay. So let's talk about caries. I mean, this is what we see every day. This is what we try to treat every day. But there's just like some more information, I guess, we can glean from the research. And so there's the research saying, like, even for just basic white spot lesions, incipient caries is showing pulpal inflammation. And that is what something we would categorize as reversible pulpitis. If you remove that, do a filling or whatever it is that you do, whatever it is that you're going to do for them, that inflammation of the pulp should go away. So chronic inflammation of the pulp occurs long before bacterial penetration of the pulp. And then I can follow that up with, irreversible pulpitis occurs when bacteria and caries is less than or equal to 0.5 millimeter from the pulp, or it invades reparative dentin. There's irreversible damage at that point. When there's about 1.1 millimeters of dentinal wall thickness from the pulp, there's very little pathology. So when I was practicing as a general dentist, a lot of times I would say, oh, this is really close. I'm going to put some medicine inside, and then hopefully you'll feel better with that. But I didn't quite understand, like the science behind it. And then we say, okay, like I'm going to put some medicine. It should get better with time. You just need to give it time, and the sensitivity should get better, right? So when we put that medicine inside the tooth, we're talking about like an indirect pulp cap, right? So when we do an indirect pulp cap, we can expect formation of tertiary dentin to begin at 19 days, and the average formation rate of the tertiary or reparative dentin is 1.5 micrometers per day. And then let me just finish this last point. Direct pulp cap is a caries exposure. When there's a caries exposure and you place liner to a direct pulp cap, has a less than 50% chance of success. So if there's a caries exposure, that's just automatically should send them to endo, because you're taking a big chance, or they're probably going to need it. So if we go back to what Reeves and Sowney was saying about you need at least 1.1 millimeters of dentinal wall thickness from the pulp. If the dentin forms at 1.5 micrometers per day, so let's just do some basic math here, okay? So we need 0.6 millimeters of dentin to form for the patient to be relieved of symptoms, sensitivity, pain, whatever it is. And if the tertiary dentin forms at 1.5 micrometers per day, you're looking at 400 days for 0.6 millimeters of dentin to form. I mean, your patient's coming back daily, weekly, monthly, complaining about sensitivity or pain on the tooth. But if you understand these facts, then you would have probably treatment planned it differently. You wouldn't have said, okay, I'm going to do a liner. I'm going to do, we're going to put some medicine and just kind of wait and see what will happen. But this right here, I mean, this is all just based on research saying, yeah, it might work. It's going to take a long time. But by then, I mean, you've already lost the patient's confidence, the patient's trust. Patient's going to leave a bad review. you'll never see them again, probably, right? So if you understand this, it should help you with your treatment planning and understanding of what it is, what we're trying to do. And I talked to Dr. Anish about this earlier. If I'm not saying don't pulp cap. Of course, it's up to your discretion and your clinical judgment. But even the materials that we use, we should have like a better understanding of what we're like the material that we pick and how it's beneficial for the patient. And so I think probably everyone at this point has had experience or has used Limelight as a liner. So Limelight is a calcium. Yes. Okay, so Limelight is a calcium hydroxide based light cured resin liner. And the research basically says that that Limelight does little to nothing for the patient. So they did research on different types of liner materials, and Limelight specifically, they looked at it, releases no calcium ions. So these calcium hydroxide liners, the way they work is it increases the pH in the area that it's in contact with, which will kill the bacteria. It also releases calcium ions and hydroxyl ions. So the hydroxyl ions will create free radicals and it'll damage the cell membranes of the bacteria. And the calcium ions will actually also stimulate the odontoblasts in the pulp to start laying down that dentin. But Limelight, literally, there's like no detectable calcium ions. And so Dr. Anish said that I guess the offices have a different material that they can use. Is that correct?
Yeah, some of the offices have MTA, so we can, if you guys are looking to place MTA, we can do that as well.
So it's like a paradigm shift. Probably the use of calcium hydroxide is really there's gonna be very specific cases that we use calcium hydroxide for. But these newer materials, these calcium silicates are just so much better. So MTA it's a little bit more difficult to use because you have to make sure that the mixing, the consistency is right. And then once you place it, there needs to be a certain amount of thickness. And then you want to place like a resin modified glass ionomer on top of it so that it doesn't wash out when you do your acid edge priming and bonding. And then there's newer materials that are coming out that are similar to Limelight, but it has the calcium silicates instead of calcium hydroxide. But some of these materials are just so new. There's not as much research. They do have BC putty and biodentine, but those materials are just very, very expensive. So if you feel comfortable using MTA, that's probably the one that I would use for these direct pulp caps, indirect pulp caps. And Limelight, again, like literally is probably doing nothing.
I have used Theracal, which is calcium silicate,
Yes.
previously.
That's a good one. I very quickly did some research about liners, and Theracal they're saying is pretty promising.
Yeah. Okay.
So I think practically speaking, I mean, numbers, men lie, women lie, numbers don't lie. 1.5 micrometers a day. That's slow. So
Right.
practically speaking, to have the patient not be in pain, you need at least 1 millimeter. So
Yeah.
I think you
Again,
just
it's
have,
like how will you even gauge that clinically? There's just no way, right? It's just like your best guess of how much dentin is left.
yeah.
So that's why like the treatment planning, looking at the X-rays and all that stuff is just so important. Otherwise, yeah, I mean there's a good chance there's going to be a lot of post-op sensitivity or pain for these patients. And so that's actually the next thing I want to talk about. So Carrie's radiographic size versus clinical size. So we always again, this is just like something I used to say all the time. What I see on the X-ray versus what I see in the mouth is not going to be the same. And I was like, man, I've been saying this for years, but I didn't have like the research to back it up. So I looked it up today and included the slide. So here, this is like the actual research that says aggressive and conservative radiographic diagnosis underestimated the true clinical extent by 0.6 and 0.91 millimeters respectively. And another study says a significant difference of 0.82 millimeters was found between preoperative radiographs and clinical measurements. Similarly, comparisons between preoperative and postoperative radiographic measurements showed significant differences of 1 millimeter. So again, you know, now what we see on the X-ray and what we're going to expect to find in the patient's mouth, we expect to find it bigger, right? So if your gut is already telling you, yeah, you're probably going to need it, I mean, I would be really hesitant to even start the treatment unless you go in there knowing that you're going to do the root canal on the tooth. So let's talk about so we can talk about some restorative topics. So this one I think they drilled it into our head in dental school. Make sure when you're working on these teeth, you use plenty of water so that there's no increase in temperature of the pulp, because an increase of 5.5 Celsius is going to cause pulp necrosis. So dry cavity preparation causes more pulpal damage than wet preparation. This is like dentistry 101, right? So again, this is like another study. Greater than or equal to 0.5 millimeters of remaining dentin thickness from the pulp is necessary to avoid pulp injury. So this is, okay. So this is a kind of something to look at when you're treatment planning these patients. The new patient comes in, or even a patient for recall. Patients have crowns and bridges, and we know from research that these FPD abutment teeth there's just like so much force on them. Sometimes you have to over prep to make sure the draw is good. It's just a lot of pressure on these abutment teeth. And so they're saying that these abutment teeth are more likely to necrose than single crown teeth. So 15%. So Bergenholtz found that 15% of these FPD abutment teeth are likely to necrose. Chung found that 30% are likely to necrose at 10 years. So you have a new patient that comes in, they have bridges. Yes, you're checking the margin for caries, but maybe you should check for the pulp vitality as well. Because if they need root canal, chances are these bridges that are 10 years old, a lot of them will probably be PFMs. We drill through them, the porcelain's going to fracture, and they're going to need a new bridge. So that's something I would definitely check, right? Just based on the research, just saying there's a good chance, or 1 in 3 could be necrosed. I showed this slide last time, but Abaras, he said that these teeth that have like multiple restorations over time, it could be really stressful to the pulp. So he called it stress pulp syndrome. So you can see tooth number 31 here, healthy, virgin, normal tooth. The pulp chamber looks normal. The canals are kind of visible, but in comparison, tooth number 30, which probably has had multiple restorations, I mean, that tooth is so calcified. So if you see something like that and you're planning on doing a restoration, check for pulp vitality, because there's a chance it could be necrotic. And then he actually recommended before performing restorative dentistry, the dentist should conduct a comprehensive pulpal health evaluation on these teeth to be restored. And then, yeah, he said they should actually undergo endo treatment before restoring.
Dr. Kwan, regarding that, if a pulp is necrotic and asymptomatic, and it has been asymptomatic, for example, like a calcified tooth, it's probably been like that for a while. What is the verbiage we say to our patient of why you need to do the treatment before you restore it?
That's tricky because if the tooth is necrotic, sometimes what will happen is like these teeth undergo some sort of trauma, and then the nerve, the pulp recedes, and we call that pulp canal obliteration. So unless the patient is having symptoms and you can like very certainly tell that the pulp is necrosed, they might not need root canal. But if the tooth is you do all your testing and for sure the tooth is necrotic, then we see, how would I word it? And you're saying there's like no symptoms, no evidence of a periapical relucency or anything like that?
Yeah, I mean, even on this PA, I don't see too much.
There's a little bit of PDL widening possibly on the mesial root, but yeah, that's tricky. I mean, just if that's the case, then just say, hey, this tooth might be dead. Let's send you over to the endodontist for them to evaluate, and then I'll take a look.
Sure.
Yeah.
Dr. Kwan, I have maybe a dumb question. Can grinding or clenching cause pulp necrosis too?
Uh, I'm not sure about it. I actually haven't seen any research articles about bruxism in terms of pulp necrosis, but we do have patients where their grinding or clenching is so severe that the teeth are worn down to like we can actually see the pulp. In those cases, if you plan on restoring the tooth, then yeah, chances are you should do the root canal on that tooth.
Okay.
Yeah. So the next topic is cracked teeth. So again, I saw a lot of cracked teeth when I was practicing as a GP, and we say, okay, you should probably put a crown on this tooth because we don't get that crack to get bigger. And so again, this is kind of like the science behind it. So why does a cracked tooth hurt? So this is based off Brandstrom's hydrodynamic theory, which he said that fluid movement in the dentinal tubules is responsible for the activation of sensory receptor units in the pulp. So cold causes outward movement of the fluid, hot causes inward movement, and that movement of fluid causes a distortion of the odontoblastic processes, which stimulates a nerve response. And so that's when the patient says they have sensitivity when they're biting. So when a cracked tooth hurts, the pieces are moving independently of each other on biting, and when returning to the original state, that fluid in the dentinal tubule moves, which goes to the hydrodynamic theory, which is the pain and sensitivity that they're feeling. So when you're doing your clinical examination and they're saying it hurts when they bite, especially biting, pain on release, this is it right here. This is why they're having pain, right? So cracks usually run mesial distal. Cracks on the DLG of the maxillary molars, you'll see that too. For vertical root fractures, it's different. And I guess I can talk about that a little bit later, but they usually run buccolingual. And then the most common teeth that present with cracks are going to be mandibular second molar, then mandibular first molar, and then maxillary first molar. And so we use like I have a fiber optic light that I use to check to see if a tooth is cracked. Basically what that does is just shines a light on the tooth, and the photons of the light, it'll go around the entire tooth, but where there's a crack, the photons, it stops. And then that will show me that the tooth is cracked. So what do we do for these cracked teeth? And so this is like a flow chart. It'll tell you exactly what you need to do for how to treat these teeth. So again, patient says it hurts when I bite. You do your vitality testing, especially do the bite test on each cusp. Pain on biting, especially on release, could be a cracked tooth. And so you need to do your perio probing as well. Again, perio probing, making sure that the perio is sound is so important. And so for a cracked tooth, if the probing depth is less than 6 millimeters, the survival rate is 90%, which is really good. I mean, but if it's greater than 6%, that drops. That number will drop. 7 millimeters, I wouldn't even touch the tooth. I would tell the patient to extract the tooth. But this is something that you need to discuss with the patient, of course, because some patients, they don't want to lose any teeth. They don't care if it's going to last a year or two. This needs to be checked so you can have the discussion with the patient. And so if they want to save it, then make sure you document saying that all of this was discussed with the patient, and the patient elected to try to save the tooth. So how can I treat it? For these cracked teeth, especially the symptomatic ones, you want full coverage restoration. The full coverage restoration is really going to prevent that crack from expanding. Otherwise, yeah, it'll just keep getting deeper and deeper. But let's say you prep the tooth. You're going to put a crown on the tooth. You prep it, you do reduction, whatever's, and you see the crack on the top of your prep, right? And that crack is black. So that black is just bacterial biofilm. The reason these cracks they get worse is just like the biofilm is in there. The PDL can't attach to the crack, and so they keep getting a bony defect. And that bacteria is already inside the tooth. If you see it's black, you probably should just tell them to do the root canal, because that bacteria will just keep getting deeper and deeper. And so the bacteria is a black pigmented bacteroides. It's like a common type of bacteria that we see for endodontic infections. So this kind of things to look for. And so another study from Sim, he said a 92% survival rate at 5 years. But if let's say it's a premolar, if you see it, so you're going to do the root canal on this tooth, and you see a crack on the pulpal floor, you should just tell the patient to extract. Because it's 11 times likely more tooth loss. Those odds are pretty bad. And again, this is a discussion to have with the patient before you even touch a tooth, so that they're aware of all the complications, all the possible outcomes, so that the patient doesn't leave pissed off. And this is the flow chart. This is what you should follow. So if the tooth is cracked, they're having symptoms, you test the tooth, and let's say it's reversible pulpitis. So you're going to prep the tooth for a crown, you're going to put that provisional on, and that temporary crown will hold the tooth together. We think, oh, it's just temporary, but no, it will help the patient actually quite a bit. And then when the patient comes for delivery, you can reevaluate and see if they have symptoms. If they have symptoms, then it's time for root canal. Okay. Once they're asymptomatic, then we can deliver the crown and then just follow up. Even after the root canal, even after the root canal is done and they're symptomatic, then they should just extract the tooth. Okay. We had a patient. I was at the Encino office yesterday, and she came to the office. She was like super anxious, super scared, and she was telling me that she's been having pain on tooth number 12 for months. She's been living off pain medication for months, popping pills every day. She saw a dentist. So she told me that she works here in LA and in London, and so she flies back and forth for work. And the doctors here couldn't figure out what was wrong, and the doctors in London couldn't figure out what was wrong. And so she came to Clove, and Dr. Ayala saw the patient, and he correctly found a crack on the tooth. And sure enough, I saw the picture, and I did my exam, and there was a huge crack on tooth number 12, going from the occlusal mesial. And so I did all my testing. There was like a 5 millimeter probing depth on the mesial of the tooth, and then no response to cold. So the crack is already in the pulp. So she's been having pain from something that could have been treated if the pulp vitality testing was done early on. And so when I talked to her, I asked her, like, did any of the doctors you saw do any type of, cold testing? Did they do anything that I did? And she said no. So it's just so strange to me that this is like the pulp testing is it's so easy to do. But doctors on both continents are just not doing the cold testing. So again, doing the testing is going to give you all the information you need to correctly treat these patients. Any questions about the cracked teeth treatment?
I have a question on your cold testing.
Oh, sure.
You said that you want to check the buccal side before you check the occlusal, or did you say not to check the occlusal and just check the buccal?
The buccal side is usually all you need. You're going to get the most accurate response by testing on the buccal. Sometimes I'll test the lingual as well, just to double check to see that the response is what I'm expecting. Like if I don't get an expected response, then I'll check like other surfaces. They never, the literature never says testing on the occlusal.
Hmm. That's interesting because I get reactions on the
Of
occlusal.
course, you'll probably get a reaction,
You know.
but probably the most consistent spot is the buccal surface, buccal
Okay.
or facial surface.
All right.
Yeah.
That's a great flowchart, Dr. Kwan.
Yeah, I mean, there's no question. So this will really, now there, again, I had so many questions about how to treat these cracked teeth, and here's the literature that says exactly what you need to do.
What are you doing these days, John, with people who walk in, patients who walk in on an emergency? It's a hot tooth, and you give them emergency treatment. You open them up, you hit them with the maybe up to a 20K file. You broach all the canals. You recommend taking them out of occlusion because they're sensitive to 3 or 4 plus
Yes, especially if
percussion.
if the patient's having like bite on percussion,
Right.
sorry, pain on bite and percussion, then yeah, I would take them out of occlusion.
Well, here's the other question. So let's say we do that because we know that when they leave the office, if they're in occlusion, it's going to be bothering them the whole day and the whole night. But what if we have a little bit of pus exudate? You leave the area open for a day or two and have them come back, or do you actually close it and put them on antibiotics or both?
So the standard of care now is to not leave it open. We don't leave root canals open anymore because we don't want any of that bacteria, the oral bacteria, to contaminate the canal. Because then the research actually says patients oftentimes end up having more pain afterwards. So we call those endodontic flare-ups. So this is another thing. I didn't put this in the slides, but if you have a patient that comes with severe pain and they've been having pain for months, there's a good chance they're going to leave with pain once you're done with the treatment. So the things are like, the research actually, this is all based off research. I'm not just making this up. So if they're female, if they have a history of pain, if they have, there's like a whole bunch of other criteria. All this, let me see if I can find it real quick. But I would give them some sort of stronger medication. I would give them steroids. If they can take steroids, I would give them Medrol. And just let the patient know, give them the worst case scenario. So because I work at the office on Fridays and there's nobody there on Saturday, Sunday, I'm going to give them antibiotics, I'm going to give them pain medication, and I'm going to give them steroids. I'm going to tell them only take the antibiotics if you feel like if your face starts to swell or if you start feeling feverish. Otherwise, antibiotics will literally do nothing for pain. But I want them to have it just in case because it's the weekend. For the pain medication, I'll prescribe them 400 milligrams of ibuprofen and 500 milligrams acetaminophen. So they're saying this, and they take it together at the same time. And they're saying that this combination of medication is going to work better than any narcotic. And I just, I hate checking cures to see if the patient's taking any type of narcotic. So this just makes it easier for me. And then again, the steroids, I just tell them just start taking it if you're having severe pain. For the Medrol, it usually takes about a day or two for it to really start working.
Another question, John.
Mm-hmm.
Patient walks in, it's a single canal, maybe it's 6, 7, 8, or 9 or 10, the anteriors.
Okay.
And it's a hot tooth again. You're going to finish this treatment in one visit, or you're going to treat it as much as you can, file it out as much as you can, and then maybe
That's
the
up
second visit?
That's up to your discretion, because depending on what you see once you get inside the tooth, if the tooth is severely infected, and once you get inside the tooth, so the patient's having a lot of pain because there's a lot of pressure in the area. Once you open up the tooth and you get some sort of drainage, that pressure is relieved. So then the patient should feel better afterwards. But if there's blood and pus coming out of the tooth, I wouldn't finish it the same day because if you can't dry it, you're not going to get a good seal when you do your obturation. So then at that point, then I would medicate with calcium hydroxide.
Mhm. Whatever happened to eugenol pellet? If you're going to continue with the second or third visit, can you put that in there?
But eugenol is good if there was like like an actual vital pulp in there. But if you're doing like a pulpectomy, that's not going to do anything. And you really should, nobody, it's just like a paradigm shift from as better materials come out. So calcium hydroxide is really going to be the medication of choice. That's the intracanal medication that endodontists recommend based off of research. There's no research that says eugenol is meant. It could be sedative. I think eugenol could be sedative for sure, but it's not antibacterial, or it'll help control like the bleeding and the pus for the following visit.
Alrighty. Thank you, John.
Sure. These are great questions, by the way.
So you could finish the endo in one visit if there's no drainage?
I mean, you could just again prepare the patient that they might have a lot of pain afterwards.
Okay.
Yeah.
It's best to do that in 2 visits? Let it all go down?
It depends on who you ask.
Yeah,
Yeah, it depends on which researcher you want to listen to. Some say one, some say two, some say more than two. So
right,
it just depends. Again, it's just up to your discretion.
okay.
Yeah. So for me, as an endodontist, I work so closely with the general dentist, you guys, the restorative dentists. We can't have one without the other. We're really working as a team here to try to save the patient's tooth. And so in this study from Ray and Trope, he looked at 1,000 endodontically treated teeth, and he said, of course, good endo and a good crown, it's going to have a high success rate. Bad endo, a good crown, actually still not bad, 67%. Good endo and bad crown, I mean, yeah, I mean, the numbers start to drop quite a bit. So I'm going to tell the patient after the root canal is done, you need to get that crown. Otherwise, all this work that we've just done is going to be for nothing because it will fail. So here, Gomez said that the odds ratio is 0.6 times more probable to observe a healthy periapical condition when you have a presence of a coronal restoration. Aquilino, endo-treated teeth without a crown are lost at 6 times higher rate. Sorensen said survival rate of endo-treated teeth with the crown is 95% versus 75.8% without. Solarabi and Rothstein, they're at USC, they did this research. Somehow they got access to Delta Dental insurance numbers, and they did like 8 years. It was like based off of 8 years of insurance information. So they looked at 1.4 million endodontically treated teeth. And so again, the word survival means that the tooth is still in the mouth. 97% survival rate at 8 years. 3% failed. Of that 3%, 85% had no cuspal coverage. So these patients, they need to get crowns. They need full coverage restorations on these endodontically treated teeth, especially for the molars and the premolars. Because again, they spend all this money, all this time to do the root canal. I mean, I'm going to make sure they leave the office with an appointment for the crown. I tell Vera to make sure that they have an appointment, the next appointment, which is going to be the restorative phase.
These numbers are staggering, Doc. What are your thoughts on closing access holes on a, what is your, if the crown was done within 5 years, some patients say the crown is good. Can you just put a fill over it?
I'm going to
Or,
say,
yeah,
for me, I tell the patient, you should discuss that with your restorative dentist.
yeah,
Because I just do the root canal portion, but then I'll give them a little bit more information. I'll say, ideally, we're trying to do everything we can to save this tooth. If it was like an ideal treatment, you would get a new crown, right? Because you're going to do the restorative doctor is going to do a buildup. If you choose to just do a filling, but these fillings, they don't bond to the material, so eventually you'll probably get leakage, right, over time. So it's not like the ideal treatment. It's more like a Band-Aid. But yeah, I mean that's usually what I tell the patient.
Dr. Kwan,
Question for you.
how good are these orifice barriers at sealing the canals?
So it's a bioceramic liner from Brasseler. And again, it's supposed to contain calcium silicates. I'm not exactly sure how good. There's no research for it.
Okay.
So, but they market it as like they don't need to be etch, prime, and bond for the liner. They just go directly on, and then it's bonded to the dentin. And the guy who kind of helped develop it is this guy from Harvard. So I'm assuming he knows what he talks about, but hopefully more research comes out, and then I'll have an answer in the future.
Okay.
Has there been any research on the patient that walks in and they don't want a crown just yet because they can't afford it, put a filling in it? I would think an amalgam covering would have more adhesive pressure against the walls of the crown than I would a composite. We all know that composites contract over a period of time, over several years. And that, to me, I would think would leave some sort of micro leakage that would endanger the success of the root canal. Has there been anything on the research basis as far as showing what type of restoration would be best? Have you read it?
For that, I mean, you have to look at the research. That I don't have an answer for. But I know, like, for me as a restorative dentist, placing composites, especially if it's like a huge filling that you're going to do, core buildups can be quite large. I'm going to place that composite or build a material incrementally, right? Again, to minimize the shrinkage, the C factor, all that stuff, I'm going to place it in layers to minimize that from happening. As far as amalgam goes, I mean, I used to place a lot of amalgams in the past, and that's like so far back in the day, I don't remember. Yeah.
What are your thoughts on the cuspal coverage being an onlay or overlay?
It's when I was in school, so I went to USC for endo. There was like this battle between endo and Prost. Prost would say they don't need full cuspal restorations, whereas so their research is saying it doesn't need it. But for us, endo, we're saying they need cuspal coverage. We're trying to protect the tooth. I don't know if they're saying that because they're trying to be conservative, but from endo research, purely just based on endo research, cuspal coverage is what we recommend.
So would that would still consider onlay
Oh,
or
full coverage. Sorry, full coverage. Full
Oh,
coverage.
okay.
Yeah. Yeah.
What about lower anterior or like maxillary premolars?
So maxillary premolars, yes, I would do for premolars, yes, I would still do that full coverage restoration. The
Sorry,
research,
not premolars, laterals. Sorry.
laterals. So the research for as far as anteriors goes, say it says it might not be necessary, but of course, if these teeth need root canals, a lot of times they have like big caries. There's caries to the pulp or whatever's right. So there's already going to be a lot of tooth structure missing. So that's really up to the discretion of the doctor. If you feel like the tooth needs a crown after, especially after endo, I mean, that's like a judgment call. But the research says they may not need it. That's the words that they use. Yeah.
Because a lot of times, laterals, after an endo treatment, you do a crown. I have seen more failures on lateral incisors after endo and a crown. So it's just one of those judgment calls
You're
that,
talking about like a restorative failure, like the tooth breaks.
yeah, it's a restorative, it's the tooth cracks right at the
Mhm.
gum line. And then you got to think, well, you prepped it, you made it a little smaller than what it is. And then, patient bites and it just, next thing you know, it's just cracked at the gum line.
Right. Yeah, I mean, endo has opinions on posts as well. I didn't put that in today's topic or today's lecture, but even for posts, endo, the research says If you have 2 millimeters of ferrule, you don't need a post.
Mhm.
The only teeth that will probably need a post is maxillary first premolars. But like you said, Dr. Puri, from your experience, you've seen so many of these anterior laterals, maxillary laterals break. They break at the gum line.
More, yeah.
Yeah, so that's a judgment call.
Mm.
Yeah.
Yeah, it's been my experience over the years I've been practicing. You put a post in, and they'll go for a few years, and about 5 to 8 years later, you got yourself a broken tooth because that post exerts a certain amount of force down the root canal, and
But see, when the patient comes in, you have to manage their expectations because they come in, that the tooth has a lot of decay, tooth needs a root canal. The prognosis of the tooth is probably already not that great. And so if they say, oh man, like you did this, the tooth broke because of what you did. I mean, they just got 5 to 7 years more out of this tooth. I mean, that's just like another way to look at it, right? Because yeah, we can fix these teeth, but nothing lasts forever, right? We don't know if there's like parafunction involved. We don't know what the patient's habits are. They might be bruxing. We've recommended a night guard and they don't use it. I mean, some of that's just like out of our control, right?
Yeah, no, definitely a lot of variables, yes.
Yes. So it's just like kind of changing the narrative. We're doing everything we can to save these teeth. We're trying to provide the ideal treatment. And again, like you said, sometimes the patient says they can't afford the treatment, and just document. I mean, that's really all we can do, right? We'll try to convince them up to a certain point, but ultimately it's their decision. And if they can't do it, just make sure you document.
write it all down.
Yeah, I mean, you saw my note.
Write it all down.
Write it all down.
That's right.
Yeah. So this, maybe Dr. Mara, our periodontist? I mean, I hope she could do a lecture for us in the future because I have like a ton of questions for perio.
Yeah.
But yeah, perio influence on endodontic success. So here the study, it says in this retrospective investigation, molars that received non-surgical root canal treatment in an advanced specialty education program in Endo from 2009 through 2017 were initially recruited. The perio status of all the included teeth were assessed based on the perio guidelines, and they were divided into 3 groups: healthy, mild, moderate periodontitis. So teeth that were diagnosed with mild periodontitis were almost 2 times more likely to be extracted compared to endodontically treated teeth with normal perio. So they're three times more likely to lose a teeth with moderate perio. Smokers were twice as likely to have tooth loss compared to non-smokers. So we need to check the perio, right? If the patient's perio is not good, they should come to the office more frequent for their hygiene appointments, 4 times a year. Again, they're paying so much money to save their tooth. We need to make sure that we're treating all the conditions. And so the takeaway message from this is that endo, perio, restorative, we're all working together to try to save the patient's teeth. We can't treat one without the other. Everything needs to be treated. Yeah. So infection is going to be like the root cause of like the endodontic pathology. And so this is like this is the most quoted article in endodontics. So it's a 1965 study by Kakashi, Stanley, and Fitzgerald. Basically, they looked at 2 different sets of rats. One was in a germ-free environment, fed germ-free food, and the other set of rats were just in a normal environment. And they exposed the pulps of both groups of rats, their teeth. The germ-free rats with their germ-free food, the germ-free food did not develop a periapical lesion, whereas the regular ones did. So basically, bacteria is the reason we have endodontic pathology. So then that kind of goes to why do poorly treated root canals have no lesion, whereas like a perfect looking root canal has a lesion. So this goes back to like there's not enough dentinal wall thickness it might be actually better to initiate the root canal because their chances are they're going to have pain, right? And then with this too, so the root canal lesion, the root canal before the lesion develops actually translate to a higher success rate for endo. Because as soon as the bacteria get inside, the bacteria from the caries, you're already looking at a drop in success rate. Okay. I showed this slide last time too, and so these are obvious cases where it probably shouldn't, it should just be extracted. Okay, so this first picture has a canine with multiple broken files. I mean, I guess we could try to take it out. It might be possible if the broken file is in the coronal section of the tooth, but it might be pretty tough. I mean, this molar with this, I mean, this is an endodontic implant in the frication, basically, right? Yeah, that tooth is a goner, right? This third picture here, so you can see the gutta percha didn't follow the canal. So whoever did the root canal, they basically created their own path. So we call that a transportation. Trying to get around the transportation is really, really tough. So for cases like this, it might be better to just refer it out for like an apicoectomy. And an apicoectomy on a lower molar, also really tough. But I mean, this patient has other things going. This, perio is on the distal is also not good. But again, an apical transportation, again, very difficult to retreat. And this last one, we call this, so you can see there's some sort of material coming out of the mesial root here. So we call this a strip perforation. So usually that will happen if the canal is enlarged too much. And then the rotary file will actually strip away the distal wall of the mesial root. And then material extrudes out into the frication. Again, so this is basically a perf, right? So yeah, maybe you might consider, like you see something like this and your gut is telling you, yeah, I don't think this is going to be retreatable. Listen to your gut. Listen to that initial instinct you have and just recommend extraction. Because if I see a case like this, I'm going to be like, oh my God, this is going to be really hard to fix. And I don't know if I can even fix it. Right. So that initial gut feeling, your instincts are probably right. Your instincts are probably right.
So what would you do with this third case right here? Would you attempt an apico on it or?
So because I'm not doing any apicos in the office, this one I would just refer the case out. Lower molar apicos are really tough. There's just like so many anatomic structures you need to be aware of, and just to try to see the tooth, it's really hard.
Yeah.
Again, have the conversation with the patient. If you really want to save the tooth, despite the perio condition on the back of the tooth, then you should get an apico.
Mm.
So what about a poorly treated root canal with no symptoms? So I got asked this question yesterday, and Dr. Anishi asked me too. So what do you do in these situations? The crown needs to be replaced, but the root canal is really crappy, but the patient has no symptoms, no radiolucency, completely asymptomatic. What do you do? So this study by Van Nieuwenhuizen, he looked at these poorly treated root canals over the course of 6 years. He monitored them for 6 years, and he said 95% of these cases were fine. He saw healing in 2.4%, and he saw failure in 2.8%. So, of course, retreat is going to be indicated if there's like you see a lesion, there's like an obvious miscanal. Then yeah, that should be treated. But for this, usually what I'll tell the patient is, okay, you're taking the crown off. This is the perfect time to do the retreat because the crown will be gone. We don't have to drill through the crown. If it becomes a problem in the future, then we'll have to drill through your brand new crown. But again, it's a judgment call. If the patient's asymptomatic, it might be okay to watch, especially based on this research here, this research article here. 95% of the time at 6 years, they're okay. But again, just it's something to present to the patient and tell them this is the perfect time to do the retreat because you're removing the crown anyways, and we don't have to drill through that.
Mm-hmm.
So let's talk about success rates. So for root canal, this is for root canal, the success rates based on work done by an endodontist. So non-surgical root canal treatment, 93% success rate, and this is if there's no radiolucency. So this goes back to what I was saying earlier about infection. So if there's no periapical radiolucency, we're looking at like a 93%, 96% success rate. If there's a radiolucency, it drops 10%. So as soon as that infection gets into the canal, they already lost 10% success rate. Or the bacteria gets into the canal, 10% drop in success rate. This retreat, actually similar, 93% success rate for retreat, 80% if there's a radiolucency, but there's a caveat to that. So if the previous root canal falls and respects the anatomy, you're looking at an 87% success rate for retreat. If there's some sort of, if they're like ledged, transported, 47%. Okay, less than 50%. I would not take those odds. I would just say extract the tooth, right? It's just not even worth it. It's a pretty big gamble. So like if there's like a ledge, perforation, strip perforation, transportation, yeah, that's going to affect the success rate of a retreat. And then in this study from Hoskinson and Ng, if there's the parl size decreased success rate by 18% per 1 millimeter size preoperative lesion. I mean, that's huge, right? So 2 millimeters, you're already looking at 36% drop in success rate. So these are the things I would consider when you decide to refer patients for retreat. Say, like, if the lesion is huge, there's a good chance it's not going to work, right? It's not going to work. But if it's like a really crappy root canal, missed canal, there's no like, they didn't mess up the tooth, it's just like a not well done root canal, there's a better chance of success. And so that actually on the opposite side of that would be if the root canal is done really well and the root canal is failing, for that too, the chance of success is low. Because if they found everything they needed to, they cleaned everything they needed to, the operation looks great, and it's still failing, chances are I'm not going to get a better result with a retreat. So then let's talk about endo versus implants. I guess implants got really big in the mid-2000s, and so a lot of studies came out from endo trying to justify our specialty. So they compared endo success rate and implant success rate. And so Doyle said there was no significant difference. It was like a 94% success rate, implants 96%, endo 94% from Iqbal and Kim. Elzar said no significant differences in terms of success rate, but implants require more interventions. So like basically they're saying having your natural tooth, your actual tooth is requires less maintenance versus an implant. So what I'm trying to say for that is like, if you can try to prolong the life of the tooth for as long as reasonably possible, and just kick the can down the road where we can just kind of push that implant back for the patient, it might be better long term. Because if an implant fails, it's a much bigger procedure to take the implant out, do the grafting, redo the implant. Whereas like if a root canal fails, just do a retreat and do a new crown. Any questions about the implants? Or do you disagree with that statement? I mean, I would love discussion. It would be nice to hear some feedback. I guess not. Okay.
And I think we're all kind of on board. You keep what you
Okay.
have, and then unless it's gonna fail, then switch it to an implant.
Yeah. So the success rates really depends on who did the research. I mean, there's a wide range of numbers in terms of success rate. So the numbers I gave you is just kind of based on the Toronto study, which I have here at the bottom. That was a pretty big study that they did. But again, there's been so many success rate research done over the years. So this is success rates for root canal treatment. And then this is success rates for retreatment. And you can see the numbers are much less. So if a patient has had a retreat before, I would definitely not recommend doing another retreat because, yeah, I mean, 40% again, that's just not worth it. I wouldn't take those odds. So that's for success rates for retreatment. So again, going back to the endo versus implants, I looked for studies that compared that there was like long-term success rates for root canals and implants. So in this study, the cumulative endodontic success rate showed that treatment success rate was at 10, 20, 30, and 37 years. So I'm just going to pick 20 years because that's the one I have for the implants, was 85%. So endo, I mean, it works. These long-term studies show that there's a very high success rate. And again, the key word is success versus survival. For the implants, this study looked at 1,440 implants that were placed, and they showed a survival rate of 88%. And it was a 20-year meta-analysis study. So actually, this was the endo study was retrospective, and the implant study was meta-analysis. So the meta-analysis in terms of scientific evidence is much higher. The strength of the research is much higher than a retrospective study. And so the way they defined like a implant success was something like if there's no like peri-implantitis, there's no like bone loss, et cetera, et cetera. So survival means like that could still be happening, but still it survived for 20 years at 88%. So again, the rates are very comparable. So again, if we can just try to prolong the life of the tooth, we should get similar results in terms of endo versus implants. I showed this slide last time. For you guys, if you're going to refer these patients to me, doing your testing, your clinical examination, this is all really important because if there's this number 8, what is it, number 18 on the left, the picture on the left here, I mean, has a gigantic amalgam restoration. Once that's removed, what's going to be left of the tooth? So Dr. Puri Senior, what would you consider as what's like the bare minimum what you would consider as a restorable tooth?
Out of number 18?
Well, I'm just talking about in general. Like what would you say, like if you saw a tooth and you say, okay, this is like the bare minimum that I would try to save this tooth by doing a crown?
I mean, you at least half the coronal structure, at the bare minimum. Where you can build on the tooths. Anything less than that?
What if there's like furcation involvement?
Yeah, depends
Do it.
on whether it's a 1 or a 2. I would definitely make a note of that before storing it. Pocket depth, as you said, perio, critically important for the longevity of the tooth and the restoration.
Right.
Furcation involvement, if the patient can keep it clean and it's a 1 or a 2, it still flies. But a 3 or a 4, you're done.
Yeah, right.
So, what is the occlusion, how much stress the tooth is having, a lot of different variables in it.
Yes, exactly. So there's a lot to consider, even to determine if the tooth is restorable. Dr. Anish, I mean, you had something you wanted to say?
No, I'm basically on the same page. I kind of factor in the patient's age as well and let them know.
So like how many walls would you say needs to be remaining on the tooth for you to consider the tooth to be restorable?
I want at least 2 walls. Yeah.
Right. So that, what you're saying, 2 walls, some people might agree, some people might disagree. So it's like what I see as restorable, you might not agree as restorable, and what you see as restorable, I might not agree, right? So it's like it's subjective, I guess, to a certain degree. But again, if you're going to send a case to me, then I'm assuming that you can restore the tooth, right? That's the bottom line, right? You check the perio, you check the restorability. All this has been, Dr. Puri mentioned a lot more variables than I was going to talk about. But again, if all of that is good, then yes, by all means, send the patient over. But if you have any doubts, that patient might end up becoming a nightmare, right? Crown keeps coming off, buildup keeps coming off. Yeah. Again, if you have that initial instinct that that it might not work, then maybe it's better off with an extraction and implant. Right. So do you still do cast posts, Dr. Puri?
No, we don't, no.
Yeah, I mean, probably haven't done one in a long time, right?
Yeah, it's been a while.
Yeah, so I mean, even for me, and when I went to dental school in like 20, and I graduated in 2013, they touched very briefly about cast posts, and then I never did one after that. So yeah, yeah,
We used to do those dowel posts, with a wax up,
Yes, the dowel and core. Yeah,
dowel and core.
right, right.
I mean, it would restore it well, but I think down the line, it definitely cracked the tooth. But yeah,
Yeah.
more.
So, because I've been referred patients that have had cast posts, and the only way for me to remove that cast post is I'm going to have to remove the crown, and then I'm going to remove the post, the cast post. And again, these cast posts are like the last Hail Mary for these teeth, because once I take that out, another cast post is going to have to be done, most likely. And even then, I don't even know if it's going to work. So if you see a cast post, you might consider extraction.
Yeah.
Yeah, because retreating too, I can do the retreat, but what about what comes after? I don't know how long that's going to last. And again, like you said, nobody does cast posts anymore. So
Right.
yeah. And then we see like these younger patients, sometimes they come with these impacted third molars and they don't listen to the dentist, surprise, surprise, and there's a huge cavity on the distal of that second molar, mandibular second molar. And then once you take out that mandibular third molar, they're left with a huge bony defect, and that caries is super low on the root. I mean, what's the prognosis of a tooth like that? I mean, that's going to be really tough to restore. And then with all that bone loss, how long is it going to last? So again, something you guys should consider in terms of long-term prognosis.
Yeah, definitely document all that. A lot of times the patient might not be agreeable for extraction, but you can definitely document that the prognosis of the tooth is very guarded because of all these reasons.
Right.
Yeah, yeah,
If the patient wants to save it, we'll do our best. And you've already discussed with them that we're going to do everything we can. We don't know how long it's going to last, but just make sure you document. Some of the offices that I go to actually have the patient sign a paper saying that they understand that the prognosis of the tooth is guarded, and I still want to continue with treatment. Yeah. So, expectations, for me, I'm going to help you with your diagnosis. If there's anything you're unsure about, please, send it over and I'll try to help with the diagnosis. If there's like any type of change in treatment plan, I'm going to, of course, I'll tell the patient and then I'll let you know too. And again, everything will be in my notes. My notes I usually try to be very detailed. So what I talked about with the patients should be in there. I'm going to do the best I can for our patients. And then when I finish the case, I'm going to leave. I put that blue BC liner on top of the pulpal floor covering the gutta percha. And so please just leave that in there. And then I'll put a cotton pellet or PTFE tape or a sponge on top of it and then put Cavit on top. And then, just obviously remove that when you do your buildup. And then, what I'm expecting from you is, of course, determine if the tooth is restorable, the perio is good. If the patient is in severe pain and they can't get to me quickly or for whatever reason, consider doing an open med. And then just talk about the treatment with the patient so that they are prepared and that they know what to expect. Because a lot of times the patient comes to me and they're like, I'm not even sure why I'm here. So please make sure the patient knows why they're being sent over.
yeah.
John,
And
let me comment on that last situation.
sure.
you got a third molar and it's a horizontal and it's caused caries on the distal of the second molar on the mandible, depending on the size of the caries, is what's going to govern really a good decision. If the caries isn't that large and you can remove the tooth decay and it's in the root, I mean, it's that low, it's down below the enamel, that's a real touchy situation.
Exactly.
You better make sure that all that tooth decay is removed and that you can get either an amalgam filling down there or you can get your margin or your crown down there. If that caries is very large, don't even mess with it. If the caries is really large, you're not going to remove all that tooth decay from the enamel on the back number 18 or number 31
Right.
and down into the root, because you're going to have that tooth fail. And now you've caused the patient $1,000. So for a root canal, you cost $1,000 for another crown. And when it fails and they come back to you and say, why did you do that for me? You're going to have a lot of headaches, and you might as well contact your insurance carrier. So
Right.
in my opinion, based on my years of experience, and I have seen this many
Right.
times,
Right.
depending on the size of the caries, okay, guys, go ahead and do it. You know, take the tooth decay out, put a silver filling there if you don't want to put your margin on there, and then document that you communicated this to the patient before and afterwards. But it depends on what the situation is. You see large caries, a lot of it, forget it. Don't even mess with it.
I mean, I agree.
You
I mean,
extract the
even
tooth. You extract the tooth. That's what you do with that.
right. Even in my day, again, I've made that mistake before as a GP. You know, when I was practicing as a GP for endo, and it's like, I mean, it's herodontics. I mean, trying to get a good margin on that distal when you're
On the margin,
on
the root.
on the root. I mean, that's like next to impossible. Get a good margin, get a good impression. I mean, that's just so hard.
That's right.
Yeah.
That's right. No, you don't do it. You just tell the patient it ain't going to work,
Right.
and that's it. Otherwise, they're going to come back at you.
Yes.
Yeah.
And just document, you know, make really good notes so that
Everything.
there.
Put it down. Put it down.
So that's my lecture for today. Any questions? It doesn't even have to be what we talked about. If you have any questions about endo, please, you know, feel free to ask. Or if you're tired, then we can call it a night too.
Thank you, Dr. Kwan. Great lecture.
Yeah. So this is my phone number. Some of the docs have already been texting me about questions. Please feel free to text me. I would be more than happy to answer any questions you guys have.
Dr. Kwan, can you share that flowchart with me, please?
The flowchart? Sure.
I have a picture of it.
I can take a picture of it. If you have a PDF, you can send it to me.
I mean, I can just share the whole lecture.
Yeah, that's fine.
Yeah, I can do that. Okay.
Thank you so much, Doctor.
If that's it, then yeah, then we're done.
Thanks, Dr. Kwan. This is Sean here. Just wanted to say a couple words. So we're trying to build more cohesion with all of the doctors. This was an amazing presentation by Dr. Kwan. And if anybody has ideas or wants to present, doesn't have to be this long or thorough.
Sorry, yeah, I didn't realize it's 7:30. Sorry, guys.
Somebody would like to present even 5-10 minutes, a couple interesting cases, or they want other people's opinions. Right now, real time, it's going to Dr. Anish. We've created the senior doctor team, which includes a lot of the senior doctors on our team. We have that email and the number that you can call and text that a lot of the team has been using for questions on Invisalign consults or tough cases. So that's the way we're building cohesion. We also created a Google chat group, which I send a couple messages to so we can have real-time chat between the doctors in case you need to message everybody. So we're looking to continue to build out this community. I think it's our biggest differentiator, and we can all learn from each other. And so, I'm spending a lot of time on how do we build an awesome culture? Because if we have a solid group of doctors, it flows down to the rest of the team. What I see in these offices is the front, the assistants, the hygienists, they all look up to you. So how you present yourself in the office really becomes the culture of all of Clove Dental. So appreciate all of your hard work. Just wanted to remind you that, and communication between us makes us all stronger together.
I have a question to Sean. The the Invisalign lecture or workshop that's coming up, is this on theory? Is this on diagnosis? I mean, what is this guy going to present if you go to his lecture and you call it a workshop?
It's on both, right? For diagnosis, you have to know the theory, but it's essentially on treatment planning. They're selling it as treatment planning, how to treatment plan, how much time to expect per, case and whatnot.
Okay, so it's not well, treatment plan, you're gonna have diagnosis, so, but
Exactly.
he's not gonna do that.
No, he is. He is. He's gonna help you with determining, what bite they have, what occlusion they have, cross bite, open bite, what to look for, and how to, communicate with the patient what they need.
Okay, thank you.
Sure.
One final note, the research articles that I presented today, there's so much research done by other researchers. And so I definitely welcome and encourage people to kind of seek their own answers too. I just look on PubMed. All the articles are on there. Sometimes we don't get full access, but there's still the abstract, and you should be able to glean to get enough information like what you're looking for based on the abstract. So, again, we're trying to do evidence-based dentistry, and all the articles are on PubMed. Yeah.
All right.
And if anybody has professors or other people they would like to come speak to our group, we always welcome that too, or any mentors or things like that. I think, they would welcome that opportunity, and we could always learn something from people in the community from USC, UCLA, Loma Linda, any schools where, people who are on the cutting edge of the research. So.
Yeah, that's true. All right, guys. Thank you so much.
Thanks,
All right,
everyone.
thank you.
Thank you. Thank you, Dr. Kwan.
Sure, no problem.
Thank
Good
you.
night, everyone.
Okay, good night. Yes, thank you, bye.
Shall I?